Thank you. Thank you very much. And thank you to the organizers for inviting me. And also, I think the order of the session so far is working really well, because I'd like to think my talk follows on very nicely from the previous speaker, because I'm going to be focusing on some of the major barriers to actually accessing diagnostics. I'm going to try not to be too depressing here, but I do think that there's some really important and very complex barriers that need to be considered. So I'm going to start with this quote, which I think nicely summarizes some of the issues. I think the availability of rapid or simple tests does not automatically ensure their adoption, and there's economic, regulatory, and policy-related barriers, as well as user provider preferences and cultural barriers. So it is a very, very complex situation. In the time that I have available, I'm going to talk about barriers to expansion or access to existing testing to improve early diagnostics, use of diagnostics, and then reflect also on some of the barriers that are specific to the newer diagnostic tools as well. And then within the first one, there's two key points that I'm going to talk about. First is the access to health services, primary healthcare services, where a lot of either the diagnostic tools or at least the healthcare provider that will refer patients to the right place to access diagnostic tools, the challenges there. And then also the presence of unregulated, lower quality healthcare providers, which I think often we don't think about enough, but is a major barrier for patients to access quality care and diagnostics. So and I'm going to be using examples from some of my work and other colleagues' work. So this is from a study on delay to diagnosis and treatment of TB. It's the largest study on delays to diagnosis conducted, and it was published last year. So what we did in this study was analyze data from Yunnan province, China, about 80,000 patients diagnosed with smear-positive TB from 2005 to 2013. And what we analyzed was the delay between patients developing symptoms and first reaching a diagnostic center that was a government-run, DOTS-affiliated diagnostic center that could provide them quality-assured diagnostic services. And then once they were in a diagnostic center, how long it took for them to receive a test result, and then from receiving a test result to initiating treatment. And it was very clear that the majority of the delay occurred, so 57 days was the median between having symptoms and actually accessing a quality-assured healthcare provider that could provide them diagnosis. Once in the system, getting the test result was quick, days to initiating treatment was quick, but the major delay happened in accessing the healthcare provider. We also analyzed working with the Yunnan CDC, what we defined as extreme delay, which was more than 90 days between symptoms and accessing the healthcare provider, and 32% of patients experienced more than 3 months or 90 days of delay between having symptoms and reaching a quality-assured healthcare provider. And the thing that I think is really important in this study context is, this is, as I mentioned, in China, there was 100% DOTS coverage, an excellent electronic recording monitoring system. So despite having a lot of the coverage that is reported of DOTS and the presence of healthcare facilities and diagnostics, there's still major delays occurring in a large proportion of patients. So why is this happening? And this is from qualitative research, both in Yunnan, where we conducted the study, but also Cambodia, where I've been working for several years now. And it's complex. In Yunnan, one of the issues was migrant workers feeling that they can't take time off and go and see any kind of healthcare provider. There's also, across different settings, a preference for private healthcare providers, often that aren't following guidelines, and this quote from Cambodia, people explaining that we don't necessarily trust the government healthcare providers. We don't think they're skillful enough, so we prefer other places. Public hospitals are very slow, people having to wait. And then also the distance and the transport costs associated with reaching healthcare facilities that might have the free diagnostics and have the quality of services, but are very difficult for people to actually get to. So accessing quality-assured healthcare services where diagnostics are available is a major challenge. Then what happens on the other side is that people therefore start using unregulated or poor quality healthcare providers or private healthcare facilities that might look nice on the outside, but what's actually going on the inside. And so this slide I'm going to take a couple of minutes on because I think it's, at least for me, was a very, very interesting and shocking study that I was involved in. So this is from work that I was conducting with colleagues in Pakistan, and it was the first time that we were rolling out gene expert machines or pilot testing their use in private for-profit laboratories. And when I was working with those laboratories and spent a lot of time with them, one of the key points that came out was that private labs want to offer tests at a fairly low cost because that's what patients want. And if they put a higher price on their test or they spend more of their own time and resources, their profit margins shrink. There's a maximum ceiling that they can charge patients. The patients are poor. So one of the laboratory owners said to me, do you know what? The most profitable way of laboratories for doing a test, a TB test, is to throw away the specimen, tell patients they're negative, because chances are that they are negative, and the patient's happy, and and it was sort of said in passing. And it really got me thinking. So this is a study that followed on from that, which involves using patient actors to go to private laboratories and take away the sputum specimen cups, and then go back the next day with so basically following their business, the business model, the way it works. But what we did was put attenuated TB bacteria in the sputum specimens that were being returned. So we knew that these were smear positive, 3+ smear positive sputum specimens that were being handed back to the laboratories. We tested 7 of the private for-profit laboratories and sent them 6 positive specimens and 1 known smear negative specimen. And so this is what we found. So 3 out of those 6 laboratories, so the ones in the middle which are in bold, said that all 6 of the smear-positive specimens were negative. So they gave the patients back test results saying that they were negative. They got the smear-negative one right, i.e. they said that was negative too. So all 7 of the specimens that were sent across were reported back as being negative. There were some that did a mix, so 2 out of the 6 were correctly identified as positive, and then there were some labs that got it all right. So that was a mix. We've got the Indus Hospital here, which was our partner, and we also double-checked all the specimens to check that they really were smear positive as going through to the labs. So as you can see, that there are major quality issues, and it may be down to training, but there's also, I think we would be naive to think that there aren't profit-driven incentives here, even at the individual lab level. So then when we reflect about bringing in new diagnostics and where these might be placed, and that the burden it might put on labs that actually really want to keep their costs lower, it's something that we often don't spend enough time thinking about, especially in relation to the fact that 60 to 80% of patients, it's estimated, will be using for-profit or private healthcare providers rather than government providers. So now I'm going to move on. So those are barriers that are going to affect all sorts of diagnostics, but there's additional challenges to rolling out newer diagnostic tools. One of them is related to how do we get these into the guidelines, how do we train providers, even public healthcare providers that are perhaps keen to follow the guidelines, but there's always delays. There's delays with actually getting the guidelines updated in high-burden countries, and then there's a lot of infrastructure and resources required to train providers, and there's who's going to organize the training, who's going to pay for it, whose responsibility is it that those healthcare providers are confident in using the new tools and updated. Is there even a database of medical providers? Once people graduate, they start practicing all over. How are we even going to bring them together? How often does the training need to be provided? Even if by some huge feat people are brought together, the relevant providers are brought together, is it just a one-off? Is a one-off going to work? And I've got down that these are challenges that are going to affect a lot of the new tests that we're thinking about. So this study that I'm going to briefly touch upon is one which the China CDC and China Medical Association conducted a pilot training a project in 6 of their provinces, where they provided update training to healthcare providers. And what we did was do a study to see immediately after the training, what was the impact on being able to follow MDR-TB guidelines, and then what happened over time. So we did a follow-up knowledge survey 12 months after. And what we found here was that, particularly if we focus on the laboratory diagnostic elements of the knowledge of clinicians, first of all, we found that before training, so that's the black bar, it was very, very low, knowing about which diagnostic tools to use and to be able to interpret laboratory tests. It jumped up immediately after the training, so that's the white bar. But then 12 months after the training, it was again, the knowledge was declining. This is perhaps not surprising, but what it shows is that it's not just one-off trainings, but a lot of investment needs to be undertaken into updating guidelines and reminder, continuing medical education, which in low and middle income countries and high burden settings, the resources are very, very constrained to be able to do that. And carrying on with the theme about the costs of bringing in new diagnostic tests, particularly when there's several healthcare issues that are competing for attention. So I think when we are here, we're in an AIDS and TB meeting, we feel like this area, this health issue is the most important, but for low and middle income country policymakers, everybody feels that their issue is the most important. So when they're thinking about bringing in a new diagnostic test, in addition to the cost of the machines, the reagents, there's import duties, there's the resources required to navigate the logistics of getting the new tests to the healthcare facilities that they're needed. And then, as I'd mentioned, if there's an engagement with the for-profit sector, there's the issues with considering their profit margins, staff training and retraining, annual calibration. So there's a lot of cost and logistics to be considered. Then also an important point when we think about equity is that the cost effectiveness of the tests will vary depending on the testing volume. If you're putting out a high cost machine and training a lab technician in a facility where there's very few patients that are going to require the test, obviously the cost effectiveness is going to be less. But then if we don't consider putting them in those sorts of peripheral healthcare facilities, then we have all of these equity issues, and only certain people are able to access the test. So it's a very difficult decision for policymakers. And this is coupled with the fact that often the evidence isn't available for them to make decisions on where these tests should be placed and how much it's actually going to cost. And I put this, the last row in my table is just to put into context how much governments are spending per capita per year. So this is a range of low and middle income countries. So it's $3 to $20 per capita. And if you think about how much some of these tests cost, this is just one test for one disease. So it's not easy. It's not an easy sell for a policymaker in these contexts. So this is my penultimate slide. These are important, difficult challenges. Are we doing enough to address them? And I would say no, because if we look at, we know that there's not enough funding for TB research, for HIV as well, but this is looking at TB research and where the funding, even within the pot for TB, is going, much less on operational research, nothing that was specifically allocated to health policy and systems research. So we're spending a lot of money developing new tools, new diagnostics, new drugs, and not nearly as much on figuring out how these are going to reach the people that need them, and how to help policymakers navigate some of these decisions. So in summary, because of various issues, there's a lack of evidence to show low and low and middle income policymakers the value of investing in new diagnostics, the usefulness of these tools. So therefore, there's not enough funding allocated, particularly from domestic sources, into rolling out the best tools for their context, which means that healthcare providers are inadequately trained, they don't have the tools at the right places, and patients will then therefore end up visiting providers that don't have the tests, or they don't have the knowledge, the technical expertise to correctly use the test when they're needed to be used. And the diagnostics that are available are then concentrated in healthcare facilities that are too far, too expensive, and too inconvenient for patients to reach. So these are the range of barriers and how they trickle down from not having enough evidence for policymakers to make the right investments. So apologies for being a bit depressing. I did say that it might be, but something for us to think about and discuss together. Thank you.